Good morning, everybody. Thank you for joining us this morning. I'm Brooke Thomas. I'm your CME specialist with Community Hospital. This morning, we have Dr. Catherine Croft presenting to us on Gynecologic Oncology for Primary Care. A few housekeeping items before we start. If you have any questions for Dr. Croft, please add those to the chat and we will answer those throughout the presentation. If you are in the room, please raise your hand. We will reread the question and answer it at that time. There are no disclosures by Dr. Croft. Community Hospital designates this program for a maximum of 1 AOA Category 1A credits and will report CME and specialty credits commensurate with the extent of the physician's participation in this activity. Community Hospital also designates this live activity for a maximum of 1 AMA PRA Category 1 credits. Again, physicians should claim only the credit commensurate with the extent of their participation in the activity. Dr. Croft is a new addition to our oncology team at Grand Valley Oncology. She joined Dr. Glenn Bigsby and Esther Canapel in practice in May of this year to offer full-time gynecologic oncology coverage to the Western Slope. She grew up in Georgia, where she completed medical school before moving to Charlotte, North Carolina for residency in OBGYN, followed by fellowship in gynecologic oncology in Charlottesville, Virginia. Before coming here, she was in practice in Rapid City, South Dakota. She is passionate about providing care close to home for patients. Okay, Dr. Croft, the floor is yours.
So much for that introduction. So let's get started. If I can get my slides to actually move. Okay, so I know she said already that I don't have any financial disclosures. I will say I am biased against the gynecologic parts. If you mute yourself, I think, okay. I just hear an echo. All right, no worries. So in my world, cancer is really common when in reality it's not. So I tend to think about cancer quite often. This lecture is going to focus a good bit on the cancers I take care of, but my hope is to give you some clinical pearls for your practice and an option to phone a friend. All right. So objectives for this talk, we're going to review the presentation and diagnosis of common gynecologic malignancies by disease site and discuss the basics of treatment by disease site just to give a framework for when you send folks to me. So it's a little bit less of a black box of what on earth do we do. All right, did we get that part? Yay. Okay, I'm not hearing an echo anymore, which is fantastic. All right, so I realized when I was putting this talk together that I focused a lot on the vulva, the cervix, and the uterus, and a lot less on the ovary. It's because ovarian cancer gets a ton of press, and the rest of them don't, but ovary cancer is the least common cancer that I've seen since I've been here. So the most common cancer I take care of is uterine, and then the most common second cancer I've seen here has been cervical, which it shouldn't be, but it is. So I see quite a bit of cervix cancer here, and I've probably seen the equivalent number of vulva and ovary cancers. So I kind of wanted to talk more about the things that I actually see more commonly here because they get less press. Like most people think about ovarian cancer, but don't necessarily think about the other downstairs lady part cancers that I take care of a lot more often. So the vulva stylized here. All right, so for our primary care colleagues, a plead for the skin downstairs. I really want to encourage folks to not be afraid to look down there, especially in older patients. I know I've talked with my general surgery colleagues that this is a challenge for the anal area as well. Women don't like to show their lady parts downstairs to new people. And particularly my older patients in their 70s and 80s, a lot of times are really nervous about having somebody look there. But treating them with a cream without looking is kind of doing a disservice because there are actually benign problems that could lead to a cancer, like lichen sclerosis, which we're going to talk about. And that you know, by finding them, identifying them, and treating them, you actually could prevent them from developing a vulvar cancer. And then you also may find out that the small problem they've been having for a week is much bigger than what you anticipate. And I've got a few examples of that. So vulvar cancer, there's 1 in 333 women will be diagnosed with vulvar cancer in their lifetime. And in 2024, there's an estimated 6,900 new cases. I see a lot more pre-invasive, so a lot more dysplasia than I do actual cancers. But since I've been here in May, I think I've had 3 vulvar cancers that I've had to operate on. And considering there's only 6,900 new cases in the US, that's not an insignificant number for just being on the Western Slope. So lichen sclerosis, and these are all almost every photo that's in here is somebody that I've actually taken care of. They're all de-identified. So lichen sclerosus is more common in postmenopausal women. We don't really know what causes it. It's chronically irritated vulvar skin. And patients will come in and they're like, I'm itching all the time down there, or it hurts to have sex. They're having burning with urination. And it presents with white patches, thinning of the skin, resorption of the labia minora or clitoris. So in this patient, what I see here is you can see this white parchment paper appearance to it, and you notice that her labia minora are completely gone. And those are hallmark features of lichen sclerosus. This is an earlier stage of it. We see some where the clitoris is completely gone and you have a small introitus in the urethra, and that's all you can see. So how do you diagnose this? You biopsy it, and it's really important to biopsy. I have been guilty of not biopsying somebody and treating them empirically for lichen sclerosus, but it's important to have a tissue diagnosis. And so a 4 millimeter punch biopsy goes a long way. Because there's also been times that I've thought that it's going to be lichen sclerosus just based off of how inflamed and irritated it looks, or how it has this whitish appearance. And with a lot of the medications we're using for type 2 diabetes now that cause people to pee out a bunch of sugar, those patients get similar appearance to it. So a punch biopsy is really important. Yeah, so the question was, do you just biopsy the kind of whitish area? I was always taught to biopsy right at the border of normal, but really I tend to just biopsy the most abnormal area and put a note to pathology on it that says, hey, I'm worried about lichen sclerosus, and this is what the clinical appearance of it is. I think that was a great question. And I think if you biopsy right on the border of it, you're not necessarily wrong to do that, but I always pick kind of that white parchment paper area to get a punch of and just stitch it or put silver nitrate in it. So one of the reasons it's so important to diagnose lichen sclerosus is vulvar cancer is a bimodal distribution. So my older patient population is more likely to have lichen and to develop something called differentiated VIN. Differentiated VIN sounds good. It is not. Differentiated VIN is the same as high-grade vulvar dysplasia. It's just the lichen sclerosus correlate of it. And so if anyone ever gets a punch biopsy that shows differentiated VIN, please send it my way, and be aware that it's actually more likely to prevent or progress to an invasive vulvar cancer, about a 50% rate of progression to invasive vulvar cancers. And the lichen sclerosus related cancers are more likely to met out to the lymph nodes, and these patients are more likely to have a worse prognosis. So treating these patients with high potency topical steroids with clobetasol ointment, and most of the time when I'm seeing patients, they've had it for years and it's been untreated. So I do 12 full weeks of nightly clobetasol, and then we'll have them do maintenance 2 to 3 times a week. Doing that can actually decrease their risk of developing a vulvar cancer. So just wanted to touch base with that. The other kind of in that bimodal distribution is the younger patient population that classically are smokers, and these are HPV-mediated cancers. Their precursor lesion is VIN3, or high-grade vulvar intraepithelial neoplasia. And keeping in mind that some patients with verrucous lesions that you think of as being low-grade, sometimes if they've been there long enough, they will have some high-grade areas in it and even can harbor a vulvar cancer. So this is actually a patient I took care of in fellowship, and you can see these really dark areas that are here. These are all vulvar condyloma, and they look like classic vulvar condyloma. But this white overlay that's here, that's all high-grade dysplasia. And this area is actually a vulvar cancer that was hiding within vulvar condyloma. And so this was, I have to say, a gratifying excision because it all came together nicely, and cosmetically was great to have all of this removed. And she did well from a vulvar cancer standpoint. The HPV-mediated cancers tend to be less deeply invasive and less likely to go to the nodes. And she's done really well. Okay, these I know might gross out some people. These patients I saw in fellowship, both of them came in with a 1-week history of vulvar itching. That is not how long these had been there. And both of these patients, their PCPs did look and sent them to us. Neither one of these cancers are resectable. Both of these patients were treated with chemoradiation. I know at least one of them had groin nodes that were positive. Both of these patients are deceased from their vulvar cancers. And so while we think about vulvar cancer as being a skin cancer, and most skin cancers we don't think of as being that deadly, people do die from vulvar cancer, and that's one of the reasons it's important to look. So those are both squamous cell carcinomas. Does anyone have any guesses for what the second most common type of vulvar cancer is? Adeno? Any other? This one always surprises me. It's melanoma. even though this is not a sun-exposed area, about 10% of vulvar cancers are melanomas. I've had one vulvar melanoma since I graduated from fellowship 3 years ago. And then this is actually a case of melanoma in situ, and this patient had had like probably 7 prior resections, which is why her vulva doesn't have really any recognizable normal anatomy. And these darkened patches that are here, that's actually the melanoma in situ that we went in to resect for the 8th time. So how do we take care of vulvar cancers? So if a lesion is less than 4 centimeters in size, we do usually a primary resection for them, and we do sentinel nodes, which decreases the risk of them having lymphedema if we're able to get them to map. We inject with indocyanine green in the operating room, and they also go to nuclear medicine for a technetium injection beforehand. And so we're looking for the hot green node. It used to be the hot blue node. And one of my attendings in fellowship, when we didn't map, used to call herself a blue loser. And so I always say we're green winners when we map. So the sentinel nodes and the ICG is kind of new in the last year or so. For tumors that we can't resect, we extrapolate from cervix cancer and we treat them with chemoimmunoradiation. And those with node positive disease as well. And if they're distant mets, they get systemic chemotherapy, usually with a 4-drug regimen. And those stage 4 cancers, I've had patients with complete responses with immunotherapy. I've also had patients who've progressed and died on it. So for what a radical vulvectomy actually looks like, so this is actually a case I've done since I've been here. This was a tumor that was almost 6 centimeters in diameter. The area here is actually pretty exophytic. And so it was kind of like flapped out and I was able to get around it. And so that's actually the post-resection here. Because her tumor was over 4 centimeters in size, she had to have both of her groin nodes like both sides completely resected, and her risk for lymphedema is really high. So for folks who are seeing these patients maybe 10, 15 years out, you may notice that they have a tremendous amount of lymphedema. This patient had positive nodes, so she's getting radiation to the groins after having them resected. And so she's very high risk for having lymphedema. And that's like a practical thing that you may see in clinic. All right, so the cervix, at your cervix, which is always a fun GYN joke. So cervical cancer is not supposed to be that common, but I've seen 9 cases since I've been here in May. I've seen more cases since I've been here than I saw in 2.5 years in practice in Rapid. Cervical cancer, there's 13,820 new cases in 2024 and 4,300 deaths. About 20% of these cases actually happen in women over the age of 65. And that's when we're supposed to stop doing pap smears. And so there are patients who should be getting ongoing pap smear screening, and we're going to touch base on that as we go through. Prevention and screening are the keys to prevention of death from this disease. So if we can prevent somebody from getting it, treat their pre-invasive disease, that's fantastic. Our goal always with upfront treatment is to cure these patients, but cervical cancer is very, very challenging to treat in the recurrent setting. We get excited when patients have a 2-month progression-free survival benefit from the treatment that we use. Like if they have 2 months until they progress, we're excited about it. And that's kind of scary. So slight moment on my soapbox. Gardasil, yes, we have a question. Yeah. So the question was about doing regular gynecologic exams on patients even after you've finished the pap smear screening, and I 100% agree. Those patients we do annual exams on, and even patients where we've changed the pap smear screening guidelines to do a once every 5-year PAPs, they still need an annual exam. And those guidelines really are based off of patients having regular, consistent screening and not having other risk factors for it. And so we'll go through a couple of special populations when we're talking for like immunocompromised patients, not just patients with HIV, but patients who've had bone marrow transplants or who've had kidney transplants. Those are actually the patients I see really commonly with high-grade dysplasia. Where we're playing vulvar whack-a-mole, trying to deal with their dysplastic lesions that keep popping up because their immune system can't handle it. So, and if you have a patient who at 63 had a bone marrow transplant, and I don't know if that's a plausible thing, but I'm guessing it probably is. Yeah, those patients, you may end up unmasking their HPV. So there are guidelines that go along with that for how frequently we screen. So cervical cancer is really bad, but it is preventable with the HPV vaccine. So Gardasil 9 actually protects against 9 strains of HPV. And nearly all cases of cervical cancer are HPV positive. Vaccinations recommended starting at 11 to 12 years old, but can be given as young as 9. And in the US, most adults have not been vaccinated because there wasn't a great amount of uptake when it first came out. And so hopefully, as our patient population has been vaccinated at an earlier age, we'll be able to have more folks who are vaccinated. And that should decrease the risk. In the countries that have had better uptake, there's already been a decrease in the pre-invasive lesions and even in cancers. Like Australia's had fantastic uptake and they've noticed a difference. And in our patient population that's teenagers and young adults, there has been a decrease, the CDC's reported. Yes.
I have a question about the vaccine. And I should know this throughout the site, but are we giving the vaccine to boys?
Yes. Yeah. Yeah.
So that's it wasn't recommended for boys initially, but
Yeah.
if they switch that over and
So
there was a slow uptake for boys at first.
So boys and girls should be getting the HPV vaccine, just to kind of sum up the discussion that's happened here.
HPV is not only
Right.
cause of head and neck.
Yeah.
Not genders.
Yes. So the other comment was that head and neck cancer, HPV is the leading cause of head and neck cancer. And so that's just another thing to kind of bear in mind, that when we vaccinate for HPV, we're also preventing head and neck cancers as well, not just lady part cancers. And it's gender nonspecific. Another. Yep. And that is what it's a challenge that we see in gynecology as well. And so it ends up putting even more pressure on our primary care colleagues because you're seeing them and they're not going to their gynecologist. And I know that when I discharge a patient from care who's had a history of dysplasia, but I never did a cancer surgery, I always tell them they still need ongoing screening and need to have an exam every year. But I think a lot of patients, and this is anecdotal, kind of use it as a reason to not go in for care. So I think the best we can do is to encourage it. Cervical Cancer Awareness Month is coming in January, and that will be one of the things that we'll be trying to talk about in the community, is the importance of having annual gynecologic care, even though the Pap smear guidelines have changed. So I think education, and any patient that I have who has an HPV related cancer or precancerous lesion, I always use it as an opportunity to talk with them about getting their kids vaccinated for HPV and also for spreading the word to their friends to make sure that they're getting their regular exams done. And the question was about patients not getting their regular screening because the Pap smear guidelines have changed. Sorry, Brooke's giving me a thumbs up. I forgot to repeat the question, so I apologize for that. So cervical cancer, the screening guidelines, I think, like I started residency and we were still doing annual PAPs, and then they got real confusing because, and there's not consensus between the American Cancer Society and USPTF, but the ASCCP, which is our like COLPO guideline foundation, endorses both of the recommendations. So primary HPV testing is an option because HPV really should triage what your risk is of developing a cervical cancer. And if you can't do primary HPV testing, then co-testing every 5 years, or you can do a mix of cytology. In general, we kind of do cytology with reflex HPV testing starting at 21 until age 29, and then do every 5 years with co-testing starting at age 30 in general. Although with the addition of primary HPV testing, that may be something that you could forego. Yes, Dr. Fulton.
Primary HPV, is that a blood test? And then the other, or is it all through Pap smear?
It's all through collecting cells. Yeah. And I actually, so I don't do a lot of screening for these things. Like I do them after they've had cancer. And so when we do a Pap brush, we get the HPV testing result back first when we do those. And you're picking up cells, and they're also doing HPV testing.
Okay.
Yeah, they're doing both of them. Yes, Dr.
Sorry, what's the sensitivity of smear?
I cannot tell you what the sensitivity is off the top of my head for a PAP. I apologize for that one. But Pap smears are very sensitive. Typically, a lack of diagnosis of cervical cancer is a failure to screen rather than a failure of screening. If that is, yeah. Okay. So the key to all of these recommendations is that patients need to be compliant and they need to not have other risk factors. So if a patient, and I frequently see patients who haven't had a PAP in 20 years, like they don't follow these guidelines, like they need to have need to have an exam. Like they don't get to skip a
Just
PAP.
remember, you're talking to guys, you're not just doing like pap smears, you're talking to them about their vaginal health, their sexual health, and so it's not just about cervical cancer, so
Yes.
you're doing a lot of things at that age, so.
So that was a comment that when we're talking with young patients, it's not just about cervical cancer prevention, it's also talking about their sexual health and like STI prevention and contraceptive and all of that too, that it's really comprehensive discussion. So there's an app, which we've had for years now, to keep track of how we're supposed to be managing these. The newer updated version of the ASCCP app is supposed to triage what you do based off of the patient's risk status. And so it includes patients who are not screened regularly. And that is, I find that the newest app is kind of hard to use because I've so rarely have patients who've had regular and consistent screening. And so if you're encountering that, I always err on the side of doing more screening than less. And so if there's an ambiguous question where you're like, should I PAP this patient? I tend to just go ahead and do a PAP on them because it's a low risk intervention that may pick something up. For patients who have HIV who are immunosuppressed, their risk of dysplasia is 4 to 5 times higher compared to the regular population. And so for this patient population, if they were diagnosed with HIV before the age of 21, they still need to have cytology done within the first year of intercourse, and they get annual cytology for 3 years. Cytology every 3 years until age 30. And this is all in the guidelines that are in there, but this also applies for our immunosuppressed patients. And I do think that sometimes we forget about those patients. And I've had patients with cervical cancer. There's a reason why patients have to have a PAP before they get a transplant. It's because you're screening for HPV. In pregnant women, you can't do an endocervical curette, like to go in and actually scrape the inside of the cervix, and you can't do an endometrial biopsy, but you absolutely can colpo them and biopsy them. They bleed like nobody's business. But those patients, so pregnant patients do get cervical cancer, and I've definitely seen it, and diagnosing it in pregnancy and knowing about it before they deliver is really important. Delivering through a cervix cancer actually worsens your prognosis and increases the risk of you having node positive disease. And those patients also, if you diagnose it during pregnancy, they might be able to have a cesarean radical hysterectomy, so that definitively treats them with delivery, or they may qualify for neoadjuvant chemotherapy while they're pregnant. So there are potentially options that may improve their overall prognosis and improve them actually being there to take care of their kid. So all right, who needs a PAP post-hysterectomy? So this, I think, is an important slide and something I really want to kind of harp on for a second. If a patient's had high-grade dysplasia in the past, even if they have a hysterectomy and don't have high-grade dysplasia on there, they have had HPV before. HPV loves the cervix because there's a transformation zone in it. It does not like the vagina nearly as much, but it still likes the vagina and it still hangs out there. And I have absolutely had patients with a history of cervical dysplasia who 10 years later have had a vaginal cancer. And they may have been told that they didn't need to have PAPs going forward, but they need them for 25 years after the last time they had high-grade dysplasia or cancer. Dr. Fulton just made a face that 25 years. And so if their hysterectomy was done for dysplasia and they didn't have cancer in it, 25 years from the time of their hysterectomy. So if their hyst was done at 45, they have to keep going with PAPs until 70. So just bearing that in mind, that's a patient population that doesn't get out of having Pap smear screening at 65. PAPs are a screening test, as Dr. Lundy pointed out. They are not a diagnostic test, or they're not a diagnostic test. They're meant for asymptomatic women. So if you have a symptomatic patient in your office and you see something on exam, they need a biopsy. They do not need a Pap smear because the eyeball test is already positive. Your eyeballs were very sensitive. They picked it up, and you're concerned enough about cancer that they need to have a biopsy. So I do have a few case presentations as we go through. So this was a patient I took care of in fellowship, 43-year-old G1P1, came in for visit. She hasn't had health insurance and she delivered her baby at age 19. As I was going through this, I realized I practiced in the Southeast because everyone had babies before 19. So she has noticed that she's been bleeding a lot after having sex, and she thought, it's just perimenopause. She hasn't had a pap smear in 24 years at this point, and she has postcoital bleeding, which is a buzzword that is super important. This patient, it's going to be, you're worried about cervix cancer until proven otherwise in this patient. And this is actually what her cervix looked like here. So this is the speculum looking in, and you can see there's this fungating mass on her cervix. So these are the options for how we're going to assess this. So A is a pap smear brush. B is a endometrial curette that we use to check for the inside lining of the uterus. C is a Tischler biopsy forceps, and D is a colposcope, where you look with a camera and put vinegar on the cervix. C is correct, yes. C is the right answer because your eyeball test is already positive. You don't need a sensitive test to pick something up. You need a tissue diagnosis with a biopsy. So when I'm doing a biopsy in the ER in the middle of the night, these are the things I bring because I need a deep enough biopsy so pathology can actually make a diagnosis. If you take a wimpy bite of tissue and it doesn't bleed, you're probably not going to get a diagnosis off of it. And they may say that it's high-grade dysplasia, can't exclude invasion, or adenocarcinoma in situ, can't exclude invasion. So I bring Moncell's, silver nitrate, Curlix with saline, and a catheter, because sometimes you have to pack the vagina, and I'll dip the packing in Moncell's a lot of times and shove it in. And then those patients usually get admitted. Most of the time, if they're bleeding that badly, they're going to call me or call one of the gynecologists. But just as a note, and it's understandable to be, if you're in a primary care office, it takes a while to do this. And if you're having a ton of bleeding, like, just phone a friend. We're happy to do it. We've got all the tools in our office to take care of them. So this patient had an adenocarcinoma. Adenocarcinomas are less common than squamous cell carcinomas. They are much more aggressive, much harder to treat. But just a note on, again, if the biopsy hadn't been deep enough, you may not have actually gotten a diagnosis out of it. If you find this diagnosis and then send them to me, I'm going to start with a physical exam. For years, technically, to stage a cervix cancer, it was a physical exam and a chest x-ray, because these are really common in third world countries where we can't get a PET CT scan. That has since changed, and so PET is part of the staging now. And I usually get a PET CT scan and a pelvic MRI to assess the size of tumor. There have been a couple of changes in the last few years. So the role of cold knife cone is like coming back in. And so if a tumor is less than 2 centimeters in size, I'll actually go in and cut out to try to get margins around it to decide if I have to do a radical hysterectomy or not. And so this patient, she had a 4-centimeter tumor and a PET that showed no evidence of lymph node mets. And 4 centimeters is the cut point between where you can do a radical hysterectomy and where you can't. And so this is a very important note on treatment. If you see a giant mass, they probably aren't a candidate for a hysterectomy. Like, if you look in gigantic cervical mass, they probably can't have it cut out because they're going to have positive margins if I do a radical hysterectomy. They're going to need chemoradiation, and no one wants a 2-for-1 deal. You do not want to have a radical hysterectomy and then get radiation because there's just a high risk of complications with it. This algorithm has gotten so much more complicated in the last year because of a couple of trials that have come out. And so that's something for me to deal with. But I think the key takeaway is hysterectomy might not be the right answer if you're seeing these patients in the office. And if they are going to have a hysterectomy, I can't do it through small incisions. I can't do a laparoscopy because of the LAC trial that came out. These patients had an increased risk of death and recurrence if they were done minimally invasively compared to open. So it took my favorite surgery, which was a minimally invasive radical, and turned it into my absolute least favorite surgery, which is an open radical, which always takes longer than you want it to and bleeds way more than you expect. But just so that you kind of have an idea for patients that are coming in. Dr. Lindy.
You said not a surgical candidate. Do they ever get downgraded after neoadjuvant rather than get surgery, or is it never surgery?
Here, it's a never surgery. There was a trial that came out last year called the Interlace study. So he was asking if you could ever operate on these patients. So the Interlace trial, these were in countries that didn't have access to radiation like we do here in the US. They got treated with neoadjuvant chemotherapy in hopes of making them a surgical candidate. And it's potentially an option, but here, because we have such good access to chemoradiation, we tend to do chemo rads. But yes, potentially, just not usually here. All right, so this is what a radical hysterectomy actually looks like. This is that same patient. We're following her along, because I managed to take a lot of pictures in fellowship. So when we talk about doing a radical, I always talk about taking the parametria, and I say we take the uterines, if my hands are the uterines at their origin off of the anterior branch of the internal iliac, and we lift them up off of the ureters. And it sounds like it's really easy to do, and it's not. And you take the upper 2 centimeters of the vagina, and you have to take the bladder pillars. So what you're seeing here in this picture, this is actually a stitch on the at the origin on the uterine side here. And this is actually the uterine vessel that you're seeing that's like 3 or 4 centimeters in length. All of this tissue here is parametria. And then this is the upper 2 centimeters of the vagina. But you can see this woman has a very large tumor. So her nodes were negative on PET, but she had positive microscopic nodes. And it's important to note that we feel nodes when we start a rad hist. And if there's any worrisome nodes, we send them for frozen, and we will abort a radical hysterectomy if the nodes are positive, because again, nobody wants a 2-for-1 deal. So her nodes were not grossly positive in the operating room. She ended up getting weekly cisplatin with radiation. This was before the data came out about immunotherapy. And then after that, she recurred 6 months later, got treated with 4-drug chemo, and then recurred or progressed through her 4-drug chemo with immunotherapy on trial, got treated with Tivdak or tizotinib vedotin, which is actually a drug we use now, like it's already approved. This was on trial when I was a fellow 5 years ago, and it's something we actually use now, like it's made it into prime time for cervical cancer, which is kind of amazing. But she ended up developing a malignant large bowel obstruction and died. So this is why cervix cancer, recurrent cervix cancer is horrible. It's probably the worst recurrence that I take care of, because patients tend to live for very short periods of time, and it's usually a very painful and miserable death. And Dr. Virgilio is shaking her head over here because she's seen it too. So if this had a happier ending, she had widely negative margins, no positive nodes, she wouldn't have needed any adjuvant treatment. She would have had annual PAPs for 5 years with visits every 3 months for 2 years, and then every 6 months for the last 3 years. She might come back to our primary care colleagues or to our gynecology colleagues if she's aged out of GYN oncology follow-up because she graduated and got to fire the oncologist, which we're not very good about letting our patients fire us, to be honest. So those patients need to have ongoing pap smear screening per ASCCP guidelines. It's not every year, but they need to be seen every year and then go for a full 25 years after. All right, so the next thing is the uterus. I got banned from using the word cuterus in fellowship because every time I said it, my attendings would go, the uterus is trying to kill this patient. You are not allowed to call it a cuterus. Okay, so malignancy or hyperplasia, these patients are going to come in with heavy menstrual bleeding, irregular periods, or postmenopausal bleeding. I have had 5 patients under the age of 30 between fellowship and practice who have had endometrial cancer. So just because they're young doesn't mean that they can't have endometrial cancer. So it's just something to always think about. And I tend to be very much in favor of biopsy. If somebody has something weird going on with their periods, biopsy liberally, because they could have a hyperplasia. It could be a polyp or something totally benign, but you never want to miss a cancer. The classic risk factors for endometrial hyperplasia or malignancy are diabetes, obesity because of the estrogen production in the peripheral fat, unopposed estrogen, which we don't really do anymore, thankfully. Although if patients are getting like hormone pellets injected, they may have higher levels of estrogen in their system and circulating in their system and may not be on high enough of dose of progesterone to overcome that. Or patients who are chronically anovulatory, like patients with PCOS. So this is my bread and butter. This is the cancer I take care of all the time. There are almost 68,000 cases in the US in 2024, which includes both sarcoma and carcinoma. And there's about 13,000 deaths from uterine cancer. Unfortunately, the type 2 more aggressive types, we used to switch these as type or classify them as type 1, which are the obesity related ones that are estrogen excess related, and type 2, which are the bad actors. We don't do that so much anymore, but I think it's a good paradigm and way of thinking about it. The type 2 ones are actually more common now. They're becoming more common, and we're having more deaths from endometrial cancer because there's more patients with these more aggressive subtypes. In general, these slower growing cancers have an excellent prognosis and are diagnosed early stage, but even the early stage high grade or type 2 type cancers, patients don't always do great from them. So super important to make the diagnosis of it. A note on here, if you ever have a biopsy that shows endometrioid intraepithelial carcinoma, it is bad. That is something we treat like a serous uterine cancer, which is a high-grade uterine cancer. And so if you ever see EIC, it's a big deal. And those patients definitely need to come to me. You all may remember this from medical school. This was how it was taught on the left. And then on the right is actually the new nomenclature that's not been fully adopted yet. Anytime you have a 4-tier system, it's really hard to actually have reproducibility amongst pathologists. And so we've kind of gone to a 3-tiered system of totally benign, pre-malignant, which is EIN or endometrial intraepithelial neoplasia, and malignant. But these are the old way that we used to do it with simple hyperplasia. And the reason I have penny, nickel, dime, and quarter here is that that's the estimated rate for how likely it was to develop into a cancer. That was the easy way for us to remember it, was penny, nickel, dime, and quarter. For EIN, which is much more reproducible amongst pathologists, there's actually a 42% chance of them having an invasive cancer at the time of their hysterectomy. And so I do the hysterectomies for EIN because of that. And I've had patients with high-grade cancers that are in an EIN on biopsy. Biopsy only gets a fragment of tissue. And so sometimes there's something worse lurking in there that you just didn't get a piece of. PCOS, yes.
So like yesterday, I saw a 36-year-old G4, P4, complains of heavy menstrual periods. She hasn't had care for quite a bit of time. She defines her heavy periods as having clots. She thought she had iron deficiency and had been on iron and checked studies. Her hemoglobin is 14.
Okay.
You get an ultrasound. It says endometrial hyperplasia, but like the measurement is like very borderline, read by radiology. Offer IUD, or are you recommending this 36-year-old otherwise low risk?
So at 36, there's no definitive. So she's talking about a 36-year-old G4, P4, otherwise healthy, doesn't have risk factors for endometrial cancer, is having really heavy periods, but they're happening every month and consistent. So that patient, first, there's no cutoff for premenopausal women for endometrial thickness at all. So if she had risk factors, I would absolutely biopsy. Like if she had type 2 diabetes and was obese, absolutely would biopsy, and had a history of anovulation. Having regular monthly cycles decreases the likelihood of her having something bad going on. And I think an IUD is very reasonable in that patient because her pretest probability of having hyperplasia or having a cancer is actually pretty low. I would say that if you put an IUD in and her bleeding is not getting any better, then I would biopsy, right? Because she could have something, she's more likely to have something like a polyp or something else in there. And you've already done an ultrasound to evaluate for anything structural. In my world, I biopsy almost everybody, but my patients that get sent to me are the ones that are high risk for having it. And so I think in that patient, it's very reasonable to not biopsy at this point because she doesn't have risk factors and is having regular monthly cycles. Yes.
Where they have services, et cetera. In those cases, should I assume it was high-grade dysplasia do the PAPS for 25 years?
So this is an excellent question about if a patient has kind of sketchy past medical history where you don't know how reliable it is, and whether to continue PAPS for 25 years. I think I'd start meeting them, would get a PAP and kind of see what their HPV ends up being. I don't think it's unreasonable, particularly if the patient has lots of risk factors we've all been exposed, most people have been exposed to HPV. Like it's exceedingly common, right? And so testing for HPV in those patients will help to guide the decision. I don't think it's wrong to continue those patients for 25 years after you meet them, especially if they've not had regular care, because all of the guidelines are based on having had regular, consistent care for those things. But that's a judgment call and a guess. I don't actually have any data to say that that's the right thing to do. PCOS, which we've all kind of heard of, patients don't have regular monthly cycles because they don't ovulate regularly. This actually greatly increases the risk for endometrial cancer, almost a 3-fold increased risk. And these are all of the patients I've had under the age of 30 with endometrial cancer have had PCOS. And they were not having regular consistent cycles and they weren't on progesterone. So these are great patients for a Mirena IUD. because the progesterone will prevent them from having will prevent them from having hyperplasia and can prevent them from getting an endometrial cancer. But if this patient that you were talking about was like, I haven't had a period in 6 months and then I started hemorrhaging, that patient needs a biopsy because they've had anovulation for that period of time. Yeah, those would work too. Yep. We have most, so the question was Kylena or Liletta, if those are acceptable. They're both, they both contain progesterone, so they would be very reasonable to use. We have most of the data with levonorgestrel IUDs with the Mirena IUD, and that's what we typically use when we're treating endometrial cancer or hyperplasia with it. To image or not to image, I'm obviously biased towards biopsying, but imaging isn't always as reassuring as you think because of the stripe question. So this is a case that stuck with me from residency because I got these answers wrong. Those are, great learning points. So there's a 7-year-old G2P2, BMI of 18, no significant medical history, and started spotting a few weeks ago, came into the office for evaluation. Options are to obtain a transvaginal ultrasound, biopsy the uterine lining, reassure her that she's at low risk for endometrial cancer, have her come back for a regularly scheduled annual appointment, and have her return to clinic in 6 weeks to assess. What would you all do? Okay. 1 or 2. Yeah, 1 or 2 are reasonable. So she had an ultrasound done and her stripe was 3 millimeters. 4 millimeters is the cutoff that we used for postmenopausal bleeding for being worried about something else going on. But she calls back in 6 weeks later and says, that spotting's back. What do you do? So have her come in for an endometrial biopsy, schedule another transvaginal ultrasound, reassure her that it's just atrophy. 1. So 1 is the right answer. That was the one I got wrong as a resident. So if the stripe's still less than 4 millimeters, are you reassured that it's just atrophy? No, exactly. So you biopsy them. What are you expecting the pathology report to say? Probably atrophy, to be honest, at 3 millimeters. That's what you'd expect. This patient had serous uterine cancer contained to a polyp. So I got this question wrong when this patient was 5 years without evidence of disease. And while this is a very rare circumstance, it just drives home the point that ultrasound isn't perfect. And so if you have something that doesn't make sense, biopsying is a low risk intervention. So I tend to err on the side of if somebody's bleeding and they're willing to let me do a biopsy in the office, to just do the biopsy. And if the patient says, I will not have a biopsy done, get an ultrasound is kind of how I tend to do it. If they feel their uterus feels really bulky on exam, I do get imaging in those patients before doing a biopsy, but you still haven't gotten out of doing a biopsy. And patients on tamoxifen need a biopsy. And ultrasound will never give you the warm fuzzies for a patient on tamoxifen because their endometrium looks totally bizarre. They get these cystic areas underneath the endometrial lining, and you're never going to be reassured by it. And so the answer is always to biopsy in a patient on tamoxifen if they're having abnormal bleeding with it, not to get an ultrasound. And then this is my caveat about the image. So a note on sarcomas, this is actually a sarcoma I took out of an 89-year-old G0 who called it her baby bump. I never found her left ovary because it had been eroded through with tumor. This was an 11-pound cancer. In general, you're probably not going to see very many of them. I've had 2 in the last 3.5 years. You're not going to get at this diagnosis generally on an endometrial biopsy because it's in the muscle, not in the cavity, unless it's an intracavitary one. So in general, if the radiologist says features concerning for sarcoma, take it seriously, send it to me. If it's a uterine issue, if it's not a uterine sarcoma, it probably should go to general surgery, who may send it to Surgeonc. No, they will get it sent appropriately. But know that sarcomas are very rare. And even if the radiologist says concerning for sarcoma, it very well may be something totally benign. So these patients, I don't send for frozen section in the OR. It's too hard to make a diagnosis of sarcoma on frozen. And so I take it out, let them look at it with all the time they need. And we don't have to do nodes for most of the sarcomas that I take out, and their ovaries in general can stay. This is a hyst that had an endometrial cancer in it. We usually do minimally invasive hysterectomies if it's a young patient that wants to hold on to their uterus because they want to use it and they're a reasonable candidate for using it. We will usually get an MRI to make sure it's not deeply invasive, and then I'll treat with the levonorgestrel IUD or megestrol acetate. If they're a poor surgical candidate, we will radiate them primarily or treat them with hormones. And because there's so many medical comorbidities that go along with endometrial cancer, it's not infrequent that I have to say, we need to fix X, Y, or Z before I can operate on you. Because, and that's the other reason that surgery can be challenging too, is they tend to have high BMIs, which make nodal assessment challenging. So I know I'm running out of time, but we'll kind of quickly talk about the ovaries. So there's benign, borderline, and malignant tumors. I want to take a moment to just say borderline tumors are probably something that they never talked about it in medical school. Maybe other medical schools did, but we never touched on them. So borderline tumors, we are understanding more and more about, but they don't invade the way that cancers do. And those, I take these out oftentimes in younger patients in their 30s and 40s. They can recur as another borderline tumor or even as a malignancy years and years down the line. And so borderline tumors are something that you might see a patient have a history of. We tend to follow them once a year with imaging if we leave another ovary in or something like that, but they don't get treated with chemo. And we can always talk more about those. I think ovary could probably be its entire talk, so I'm going to hit on kind of the main things. Is this mass benign or is it cancer? It is 3.3 kilograms and it is 25 centimeters in diameter. Benign, yes. Okay. The ovary conundrum. I get sent a lot of stuff where we're like, is this cancer? Is it not cancer? In general, the bigger, the better. If it is huge and it has not spread anywhere else, it is usually not cancer. It might be a borderline tumor at worst. Cancers like to make friends with their next door neighbors and they like to spread to other places. So for something to get that big and not have gone anywhere else, it's much less likely. Please do not order annual ultrasounds and CA-125s for ovarian cancer screening on your patients. There is not data to support doing that. And actually, even in high-risk patients with BRCA mutations, they've taken that out of our guidelines from NCCN to do annual ultrasounds and CA-125s because it gives us false reassurance a lot of times that everything's okay. And because most ovarian cancers actually start in the fallopian tubes and fling off wherever they want, an ovarian mass oftentimes is totally benign and not something that we're as worried about. It's when they've got fluid everywhere in their belly that it's a problem. So for cell types, we've got epithelial, sex cord, stromal, germ cell, and then metastatic tumors can all go there. If there's bilateral masses, I always think about metastatic tumors, and that kind of guides what tumor markers I get. Sex cord stromal tumors actually make hormones like estrogen or testosterone. So these patients may come in with like voice deepening and hair growth changes, male pattern baldness. And those tumors, if they are Sertoli Leidig's, are really, really nasty and really aggressive. I've had a handful of those over the years. And epithelial is the most common that we see. This is what comes from the fallopian tubes. There's actually no epithelium in the ovary itself. So it comes from the evil fimbria. Yes, which is what I say to patients. In general, simple masses that are homogeneous throughout, like solid masses, they're going to be benign. There's thickened septations with lots of blood vessels in them. They're more likely to be cancerous. If there's free fluid in the belly, we have to think about cancer. And if it's a mixture of cystic and solid components, then cancer is always on the list. So this is a patient who their mass has calcifications in it and a cystic component here. And so this is technically a complex ovarian mass. Ultrasound is always going to be better than CT, but I look at a lot more CT scans than I do ultrasounds as an oncologist. This ended up being a serous cystadenofibroma. It was totally benign. There's no fluid in the belly. There was no mental cake or anything like that. But this was sent to me for concern for cancer because it's a complex mass in a patient who had a prior hysterectomy. I usually get a CEA and a CA-125 plus or minus a CA-19-9. If it's a young patient, I get young patient tumor markers, which are AFP, LDH, beta-HCG, and inhibins, which are for those germ cell and sex cord stromal tumors that are pretty uncommon in patients who are postmenopausal. CEA can be elevated in smokers, so just a note. And I don't tend to get OVA1 or Roma scores or any of those things. So if you see a note from me and you're like, why didn't she get it? It's usually because that's deciding whether to bring a friend or not to the OR to decide for staging. And since I'm the friend they bring, I tend not to get it. If I see something worrisome on ultrasound, CT is going to be the next thing that we end up getting because it'll give me a lot more information. And so this patient has ascites that you can see around the liver here and a mass in her pelvis with fluid around it here. And this is what ovarian cancer looks like on CT scan. I don't have nearly as many pictures of actual ovarian cancer surgeries because they're almost always done open. So I don't have a lot of pictures. So this picture, does anyone see anything in here that looks goofy to them or worrisome to them in the CT? Yes, omental caking. So there's the arrows there. Yeah. So you shouldn't really be able to see the omentum on imaging. And so if you see it, you always have to think about it. This patient doesn't have ovaries. So what is it? This is primary peritoneal cancer. It's a spectrum. So ovarian cancer, fallopian tube, and primary peritoneal cancer are all the same type of cancer. One is not better than the other. They're treated the same way with chemo and surgery, staged the same way, and one really isn't worse than the other. I want to say ovarian cancer is not an immediate death sentence. It's bad. I don't want anybody to have it, but it is something that patients do live with it, and it has a high likelihood of responding to chemotherapy. So we get about 70% of patients into complete remission between surgery and chemo. About 15% have a partial response and still have disease left at the end, and about 15% do progress on chemotherapy. But we do get people into complete remission. Unfortunately, 80% of those patients are going to recur. And so, but patients can live with disease for years. So it's not uncommon for ovarian cancer patients to live 5 to 7 years after diagnosis.
Where it's located, is it automatically stage 4?
Could
it still be in stage 3?
So primary peritoneal cancer, if it's in the omentum and it's more than 2 centimeter implants, it's a stage 3C. Stage 4A means that it's gone into the pleura of the lung and you have an effusion that's cytology positive. So primary peritoneal can be exactly the same stage as ovarian. And they almost always present with an omental cake. So large volume ascites, usually I can't operate on up front, but like the other patient, I did an upfront debulk on. Mutants do better. Ovarian cancer patients have a 20 to 25% chance of having a germline genetic mutation. Usually it's a BRCA mutation, BRCA1 or BRCA2. This is data from SOLO1. This is like where GYN oncologists completely nerd out. So these patients got 2 years of maintenance Lynparza. So they all came off of Lynparza, which is a PARP inhibitor that's specific for patients with BRCA. And I can go into nerdy explanation about that at another point. But they came off of treatment with this maintenance drug at this point. And you can see that these curves are still separating out. So this was the update for follow-up. And at 7 years, 67% of patients who had gotten 2 years of Lynparza were still alive, which is kind of amazing. So this has been a complete game changer in this. We have tried to PARP everybody because it's such an exciting drug. And this is a reason for genetic testing. If you have a patient in your primary care office who somehow managed to get discharged from GYN oncology follow-up with a history of ovary cancer, we tend to hold on to these folks. But if they somehow managed to get discharged, you may have somebody who didn't get genetic testing because panel testing really didn't become available until 2013 when the patent went away on BRCA. And so just keep that in mind. And if somebody has a family history of ovarian cancer, pancreatic, all those things, and that's another lecture in itself. We do have a fabulous genetic counselor here, Rachel Lawrence. I wanted to give her a plug here. And we've got questions I know we've been answering long, and this is my contact information. It's got my cell number in it, and that's me and my dog Iggy. So I'm sorry to rush through those last few slides. I just knew I was running out of time. Brooke gave me this thumbs up. So thank you.
Very much. Dr. did a fantastic job on the DJ.
Thank you all.
Excellent job. Thank you so much.
Thank you.
Wishing everybody happy holiday season.
Fabulous. Thank you. Wasn't all vulva pictures.